Right, ladies and gents, let's move on to the next. It's a collaborative effort by Lara van Heerden and Adele Snyman. So they're going to talk from an OT and a physio perspective on a reflection on a high-risk baby follow-up program in a rural setting. Now, Lara completed a ComServe at Manguzi Hospital, which sparked a passion for rural therapy. And she worked in private for a while completing her OMT qualification. And then she returned to rural in 2019 when she started working at Zitulele Hospital. Interesting. Also passionate about providing holistic care, implementing systems that allow for the continuity of care. Sounds awesome. She has a broad variety of interests, especially high-risk infants and their moms, with the multidisciplinary team. And then Adele, is she going to join us online? Okay, awesome. So Adele Snyman did a ComServe at Zitulele Hospital and then moved to Tshwane, so up in Gauteng, global country, for a few years where she worked in a neuro rehab unit whilst furthering her studies, and then returned to Zitulele Hospital where she works as an OT. Okay, she's passionate about rehabilitation and trying to provide quality care in a rural setting. Well, ladies, welcome.
Can everyone hear me from this angle? It's fine. If it's far away from me, it's a bit better. Okay. All right. Okay, good afternoon. I'm Lara van Heerden. I'm a physiotherapist, and my colleague Adele Snyman is joining us online. She's an occupational therapist. And together we worked at Zitulele Hospital, which is situated at DP Rural Hospital and DP Rural Eastern Cape along the Wild Coast. This afternoon, we're going to be telling you about the high-risk infant program at Zitulele Hospital and how we revised it after looking at the neurodevelopmental outcomes of babies 2 years after they've been admitted to the program. Okay, so a high-risk infant is a newborn baby who requires more monitoring and care than what would normally be provided to a healthy infant, and they also have higher risk of neurodevelopmental disabilities. Okay, so early childhood intervention has been shown to be very beneficial. In fact, the earlier the intervention can be provided, the better, due to increased neuroplasticity in the infant, and this allows for better positive outcomes for therapy. A study conducted on high-risk infants showed that those who received early intervention within the first 12 months of life had improved motor and cognitive outcomes when compared to high-risk infants who received intervention after the first 12 months of life. So therefore, again, highlighting the importance of early identification and early intervention. For this reason, the United Nations recommends that governments establish systems of early identification and early intervention in their health services. But unfortunately, this is not current practice in South Africa, and only 10% of public hospitals provide some form of infant screening, and less than 1% provide universal screening. This has resulted in disabilities being detected much later in life. Due to the shortage of rehabilitation professionals and the high number of high-risk infants born in rural areas, it becomes nearly impossible to monitor each infant in terms of their neurodevelopmental outcomes. And Martino suggested that it's actually not necessary to follow up on all high-risk infants, and suggests that our limited resources should be focused on those who are most likely to experience developmental delays and disabilities. Okay, so at Zitulele, we have a high-risk infant program. How that works is that all infants that meet our inclusion criteria, which I'll show you on the next page, have a profile that's opened, and in the ward, each child receives neurodevelopmental support, and the mothers attend educational groups where we teach them how to support their infant. So with KMCing, nesting, and how to handle and care, because mothers obviously also are really nervous to handle their tiny babies. And then after discharge, each high-risk infant is followed up every 3 months at the hospital, where the assessed and intervention is given if needed. And after a year, if they are meeting their milestones, they are discharged from our program. And if not, they continue in our program and then go into a CP group or into to more individualized care. Okay, so this is our inclusion criteria. which is quite extensive. And babies only needed to have met one of these criteria to be entered into our program. Okay, so when we reflected on our program, we saw that we had a large quantity of infants that were admitted into our program, and they became too numerous to follow up well. We have made endless phone calls and trying to get patients to follow up and book them into clinics, to see them at clinics or at the hospital, but we really battled. And despite our best efforts, most were not followed up at all. We didn't know the neurodevelopmental outcomes, and there was also limited research applicable for our setting, which made benchmarking our program really difficult. So the two of us teamed up to do an observational study by looking at the neurodevelopmental outcomes of the children recorded in the high-risk infant program. Using this information, we aim to reevaluate and adapt the program to use the resources we have optimally. So originally, we thought we'd look at the data from a poor outcome versus good outcome perspective, but we had an overwhelming amount of data. And so we decided that didn't give us much information. So as you can see between the two charts, it didn't show us anything major between the two. So we decided to simplify it and look at the inclusion criteria a bit more specifically to see if it gave us more information as to how to best use our resources. So that's what we're going to look at now. So in the 2 years that we looked at, there was 235 babies admitted into our program. 71% were lost to follow-up. And this is despite our best efforts of phoning them, booking. Even if we did book them, a lot of babies didn't, or like mothers and babies didn't pitch up to the booking. So we spent a lot of time on the phone. 29% we managed to follow up with, and 66% of those had good outcomes, while 34% had poor outcomes. Out of the poor outcomes, 82% were put into a CP group, while 17% followed up as a PEDS follow-up. So these were usually babies that were more syndromic, or we had a question mark against their name and we weren't quite sure what was going on. Okay, so the loss to follow-ups were a really big problem. And we found a study that was done at Umtata General Hospital, and they found that the three main reasons why there was patients didn't attend therapy was, one, due to finances, due to the long distances needed to travel, and then a lot of people changed areas. And these are the same reasons we think we had a lot of loss to follow-up as well. We fall under the same district as Umtata Hospital, so it's pretty much, yeah, similar. Okay, so now we're going to look a bit at a few of the inclusion criteria. So with low APGARs, 59% had good outcomes and 41% had poor outcomes. So it's quite close. And then with prem babies, 70% had good outcomes and 30% had poor outcomes. And then of the children with confirmed CP, 63% had low APGARs, 26% had prem, were prem, and 74% were born full term. So what we really found interesting is that out of the prem, 2 of them had low APGARs. So out of the 5, 2 had low APGARs, and 3 of them had no other complications. So if we had to remove prem babies from the high-risk infant program, we would have only missed 3 CPs, but we would have cut down half the amount of work, or like entering the amount of babies we did. Some other interesting facts that we found was 53% of babies who had seizures had poor outcomes, 55% of babies with born with HIE had poor outcomes, and 43% with sepsis had poor outcomes. Okay. Then we looked at the methods of delivery. So these are all different. Instrument was mainly vacuum deliveries. And what we found interesting here was that 66% of babies born before arrival had a poor outcome. And 94% of these babies were born prem. And the one of them that was born full term was born to a mother with intellectual impairment. So it was important for us just to highlight this, as there's often a lot of negative connotations associated with born before arrivals. And it's often we always hear the whispers of, if this mom could have got to the hospital earlier, if the mom was better planned, if she had booked her pregnancy better, she maybe wouldn't have had the situation or the outcome. But as you can see, 94% of these babies were actually born early. Okay, and after looking at our data, we decided that we needed to revise our inclusion criteria. We needed more education in the ward, with emphasis rather focusing on educating and empowering the moms rather than being therapist directed. So the moms could identify if there was a problem later on and come back to hospital because of our loss to follow-up rates. We also saw value in using our referral system as a safety net. So in our area, we had mental mothers, community disability workers, and community health workers. So we saw value in referring our high-risk infants to those referral systems, to provide a safety net that if anything was picked up, they were referred back to a hospital. And that SAM babies were to have their own program, potentially spearheaded by dietitians. We also made the recommendation to decentralize the high-risk follow-ups to clinics, just to cut down on the cost of travel and the distance needed to travel. Okay, so when we looked at our new inclusion criteria, which you can see is a lot less, we decided to do the follow-ups a bit differently. For premature and low birth weight with no other complications, we have thought to give them a follow-up date 6 months later, as opposed to every 3 months. But if they had any other complications, they'd be followed up every 3 months. And our findings correlate with those of Martino, who suggested that premature babies don't need to be followed. To add to the inclusion criteria, the born before arrivals, as a high percentage of these had poor or no developmental outcomes. And then to end on a hopeful story, it's easy to enter babies with the inclusion criteria that they do have and think that, oh gosh, what's going to become of this baby? So this is miracle case number 40, who was born a twin, and the twin actually passed away and was born at 23 weeks. A breech delivery, was delivered then via C-section. Low birth weight, was resuscitated, given oxygen support, developed sepsis, respiratory distress syndrome, meningitis, and then was discharged, meeting all milestones. Thank you. These are our references.
Laura, okay, thanks. I think that was quite significant. Thank you so much. That was a brilliant study. Really, it was inspiring. Willie, any question from your side?
So this is where Adele might just jump in as well.
Sorry, I thought that's excellent. The 70% that's lost, I would argue that most of them are normal.
So that is what we have kind of presumed from that.
Yeah.
A lot of mothers, when we did phone them, they would say to us, why do we need to come back to the hospital? My baby's fine. Nothing's wrong with my baby.
Yeah.
So those ones even those ones that were lost to follow up and we managed to book them and they didn't come, those are often the moms that would say, my baby's fine, I don't need a reason to come to the hospital.
Yeah.
So
yeah, I suppose you can't say
that,
but if, I would argue that there is a problem if then mums would be inclined to get easier back. That's just how
that was our thought as well.
Right, guys, any other questions?
Hello, Laura. Two quick questions. Did you stratify the low birth weight babies by birth weight? Because I mean, I would intuitively think that 900 grammers are going to be more likely to have issues than the 1900 grammers. And the same question about the APGARs.
So just in terms of our, Adele, you can also jump in there. But in terms of when we looked at our data, there's an overwhelming amount of data. So we didn't go into specific details, but when putting our data into a sheet, we did mark those who were less than 1,000 grams and those that were above 1,000 grams. And then for the APGARs, we didn't really do that. Yeah. I don't know,
Maybe I
Del,
can
do you have
jump in
anything
here.
Yep.
Sorry, I've got the sheet open in front of me. And so yes, our low birth weights, we divided into above 1,000 and then below 1,000, like Lara said. For the APGARs, we have got it all recorded, but it was just easier for the presentation to look at them as a whole. Because yeah, our numbers were quite few when we started dividing them. I'm happy to give you the answers though, Ben.
Since you put some people's follow-up dates at 6 months instead of 3 months, have you noticed a change in your dropout rate at all? Because to wait 6 months for a single rehab appointment, it's often out of sight, out of mind.
So, do you want to say anything, Adele?
You can.
We haven't implemented it, the new change in it. It's, for me personally, very hard to say, we don't need to follow up on the prems as much as we thought we need to. But yeah, we haven't yet actually implemented it. But that is one of the concerns, that if we put it too far away, that's why we thought 6 months instead of a yearly, but later on in the year.
So if it's more to do with saving the mother the cost, then I understand it. But if it is a workload thing, when we did our calculations as to whether to include an additional criteria into our high-risk baby program, when we did the calculations and stratified it by follow-up at clinic level, it was actually such a negligible increase in workload that it was insignificant, wasn't an argument.
Thank you, guys. Any other questions from the back of the gallery?
Who are you going to send this to? In the points of intervention clinically, and in this modern age, we actually have to pair clinical and medical legal learning together, because we just have to save our health system, and this is such a key target audience for them. But I think for all of us, wherever we're practicing, actually, this is really, really useful way of thinking about it. So just so well done.
Sorry, I also want to add there that I think I've come from 2 hospitals where we had quite an established therapy team and was quite well staffed. One of the other reasons we also were looking at this was that a lot